Hi guys, it's Dr. BT, and I'm going to be talking to you today about the antepartum patient and care of the antepartum patient. We've already discussed this is going to be Module 1, and it relates to conception and fetal development. Anatomy and physiology of pregnancy are really prerequisites, and they're in your book, pages 265 to 282 and 283 to 289. There are 2 quizzes which you've already mastered, and so I feel confident moving forward that you have the full understanding of fetal conception and development during pregnancy. We've talked about this. This is a lecture all on its own, and so we will answer questions about this graph during class as it is very complex. So during the reproductive years, you have a maturation of the women's genitals. This is the vagina, and you can see that it's rugonated. It has this vertically lined tissue, and that's in the presence of estrogen. Here's the cervix, which is the bottom of the uterus. The cervix, it's going to open, allowing the contents inside of the uterus, which is the baby, to escape. The top of the uterus is the fundus. We say this word over and over and over. Very important as we do assessments on fundal height. That helps us to measure fetal growth. During maturation, the endometrium is the lining of the uterus, which will proliferate and shed in anticipation of pregnancy. Once pregnancy is achieved, the fertilized ovum will come down this fallopian tube, dump out of the fallopian tube, implant in the endometrial lining, and from that point it changes its name from the endometrial lining to the decidua basalis. The decidua will remain in place until the end of the pregnancy, and it will shed off thereafter. So you do not have a period during pregnancy. Something else is bleeding, and we need to look at the cause of that, but it certainly isn't a menses. And then you have to really understand that when this decidua comes off, it then is your menses. So you clinically had a menses at delivery, and so you will ovulate at an unknown time afterwards. So the sperm and the ovum, we've really talked about this. The sperm lives for 24 hours and the ovum lives for 72. And so, you know, you've got one shot a month to get pregnant. Males are what's responsible for the sex of the baby. All female ovum carry 22X. And then the male sperm will either carry 22X or 22Y. Thus, a female will be a 44XX, and a male will be a 44XY. So, very important about fertilization. Most often it occurs in the fallopian tube, almost always. And then with the use of peristalsis, it will migrate down into the uterus. This is a great video to watch. This particular first stage is just amazing. It's a zygote first 2 stages here. And it will continue to grow. Here's the morula, and then here's the blastocyst. This picture that I'm kind of over, let me move a little bit. This is the head to bud, and this is around 3 weeks, and you can see that we've got a lot of structures in place that are developing, and the midline comes together during this time. So you guys, it's of utmost importance that the very first 8 weeks after menses is the most critical time of organogenesis. All these organs are forming, and we do not want any exposure to teratogens. Exposure to teratogens can make a congenital malformation that the child would suffer with for the rest of his or her life. And again, here it is, the schematic that we've talked about before. I'm going to move myself to the middle here. So here is the ovary, and you can see here's a follicle maturing. We'll get a big spike in luteinizing hormone. It will pop off this egg into the fallopian tube. And then fertilization will occur in the fallopian tube. You'll see cleavage around the first day. 2 cells split already. And then around day 6 to day 10, you'll have implantation into the uterine lining. Most of the time there is some spotting with this implantation, because it is so vascular. The endometrium, which is now the decidua, is very vascular, and that is how the embryo will receive oxygen and nutrition from this vascular decidua until the placenta grows and takes over at the end of the first trimester. So very important. And then here you can just see the same thing. You can see this is the uterine glands, and you can see how this pregnancy is growing, and all of this these glands are very vascular, and it's supporting this embryo as it grows. This is just a great video. I encourage you to watch it. It just shows the sperm getting trapped in the cervical mucus and being transported to Mecca. It shows fertilization, then it shows the baby growing. So it's a great video. So take your time and watch it. All right, so we need to talk about this. So pregnancy and how it's divided. There are phases of the childbearing year. Ante, of course, means before. Partum means delivery. So the antepartum period is the period from conception to the onset of labor. So we always talk about antepartum this, antepartum that. It's because they're still pregnant. It's called antenatal or prenatal. It's 40 lunar weeks, 10 months, and there's 3 trimesters. Of course, 1 through 13, 14 through 26, and 27 through 40. So by definition, there are 2 patients. Obviously, there's a mom and a baby. So what one does affects the other, and what the other does affects the other. So what if mom has an exposure to drugs or cocaine, it can affect the baby. If baby has a fetal bleed, that can affect the mother. So there are 2 patients this entire time. Intrapartum, obviously intra in the middle of parting, is the period of birth, and the first few hours after birth, absolutely up to 4 hours, because we really worry about bleeding that immediate period after birth. And then postpartum would be after that 4 hours up to 6 weeks after birth, and that's because mom is trying to get back to normal, and we're watching her pretty closely. There's 2 patients. I've seen this word pop up on NCLEX. It's called the partuient. It refers to the woman during the childbearing year. So sometimes on questions, they'll say the partuient. Well, you have to know that that's the mom during the childbearing year. She has some risk. She has some estrogen risk. She has some risk for DVT, thrombosis because of elevated estrogen. And of course, she has risk for depression. This can be anytime during the pregnancy or after the pregnancy. So the embryo, so make sure that you call the fetal structures what the actual names are. So the embryo is from 15 days to 8 weeks. And this is the most critical time that we do not want mom exposed to teratogens, pesticide, dry cleaning fluid, drugs, ecstasy, heroin, anything at all. Antibiotics even. We don't want baby to be exposed because this is the time when there's the congenital formation of the organs, and it's super important for us to, we want to see a good outcome for the baby, so we don't want any exposure. The fetus is from 8 weeks until birth, so we'll say fetal. Let me move myself over here. We'll say fetal after the 8-week period. Neonate is birth through the first 6 weeks of life, so we say neonatal after the baby's born, and then infant is the first year of life. So you guys, I have this form and you can download it. It is the standardized prenatal care for women across the nation. I do love that we have a standard prenatal care form that's evidence-based and driven. And this form is from the American College of Obstetrics and Gynecology. They're the governing body for obstetrics. So I do refer to this form, and I have parts of this form in this lecture so that you can see where that you're understanding and meeting the standards. So how does someone know or think they're pregnant? This is a great question. So someone says, I think I might be pregnant. So there are 3 different signs of pregnancy. So, and these will be on your test, and these are on the NCLEX. So presumptive, I presume I'm pregnant. So there's really not any clear evidence or data other than symptoms. So there are changes felt by the mom. Amenorrhea, meaning she missed her period. That could be stress-induced. It could that amenorrhea in itself is not a definitive sign of pregnancy. Fatigue, moms can say, I'm really tired, I feel like I might be pregnant, and so fatigue can be a presumptive sign. And then breast changes or tenderness, and when you're stressed and your hormones are a little bit hypersensitive due to stress hormones elevating what you feel, you can have some of these changes, but these are just presumptive. These do not mean you're pregnant. Probable signs of pregnancy, so things that we see that we say they're probably pregnant. These are things that I can observe as a clinician, or you can observe as a nurse. Urine pregnancy test, so UHCG is positive. This is when the chorion secretes human chorionic gonadotropin, HCG, and it is indicative of pregnancy. However, there are some types of cancers that you can have a positive HCG with, and we caution people to think just because there's a positive pregnancy test that 100% they are positive. The likelihood is very high that they are pregnant, but we also do a confirmational ultrasound to make sure as well. Chadwick sign is a bluish coloring of the cervix. It's because it becomes very vascular. All those vessels dilate so that the decidua can get as much oxygen and nutrients to the baby. The uterus completely dilates, and there's a lot of blood flow going to the uterus. So that's why there's a bluish coloring of your cervix and your vagina. Hagar sign, softening of the uterine isthmus or the sides of the uterus. It gets a little bit softer. And then Goodell sign is softening of the cervix. And then positive signs of pregnancy, or these are signs that can only be attributed to a fetus. Let me move myself, I'm on top of the fetus. Only be attributed to the fetus. So, hearing fetal heart tones. So you put a Doppler on her belly and you hear a heartbeat that's 140. Well, the first thing you need to do is go do a radial pulse and check it and make sure mom's heartbeat is not 140. So you need two different pulses. So as long as we've got mom's heart rate, I usually like to do a heart rate before I get started so that I know what it is, and then I tell her, oh, your heart rate's 80, and then I use a Doppler and go listen for a fetal heart rate, and then I can hear one, that's 120, 140, 160, somewhere in there, and I can tell you that's your baby's heart rate. So two different heart rates. Visualizing the fetus on ultrasound, obviously seeing a fetus in utero would tell us that yes, 100% sure they're pregnant. And then thirdly, palpating fetal movements is 100% attributed to a fetus. So nothing else can grow in there and move around. Palpating fetal movements is the last way to know for sure someone is pregnant. I'm sorry. So here's the ACOG record, and you guys have done a quiz for EDC, figuring out your EDC or EDD estimated due date, and this is where you would fill it in. It would say, here's our initial exam, and this is when we would palpate the uterus and kind of see what we think, and then what our ultrasound dates were, and then what our final due date was. So anatomy and physiology of pregnancy is extremely fascinating. So we've already talked about the uterus. The uterus is the muscle that holds everything for pregnancy. The uterus is really the only place capable of sustaining a pregnancy. The placenta is the oxygen tank in the buffet. So the placenta just really brings the food and the oxygen to the baby and transports the CO2 and waste away. The intravillous space is the little tiny space between the placenta and the decidua, that there is an intravillous gap where there is no blood flow, but there is a passing of oxygen and nutrients and CO2 and waste back and forth from mother to baby and baby to mother. Also, medications can go in that space, as well as antibodies and antigens. So it's very, you want to be very careful when exposing them. The umbilical cord is part of the placenta, and it just delivers. There are two arteries which take away the CO2 and waste, and one vein which delivers Jenner and the oxygen bar. The amniotic sac is composed of the amnion and the chorion. There are two membranes that rub against each other. And this is a double layer protection from bacteria that can come up through the vagina. So it's a sealed, sterile sac, which the two linings is better than one. So if there's a little tiny piercing in one of the two linings, you have the other lining. Amniotic fluid is there to suspend the baby in the uterus. It's warm. Baby does not have to regulate his or her temperature. They're in the hot tub. They are floating in the hot tub. They've been in the hot tub. So when they come out, it's essential to keep them warm the first 3 days until they can learn to self-regulate their temperature. And we'll talk about ways that they can compensate those first 3 days. But in the uterus, they do not have to keep themselves warm. Mom regulates that for them. The fluid holds them up so their limbs can grow and they don't have contractures. They also inhale the amniotic fluid in a breathing movement that helps mature their lungs. And they exhale it, and they also drink it and urinate it. And remember, urine is sterile, so it's still a sterile environment. They urinate it, and that tells us that all is well. Okay, and we've already seen this, and this is one of the condyletons, and we can see how the CO2 and waste comes up into the placenta, into the condyleton here, and here is the maternal decidua, and you can see this little bit of intervillous gap, and that's where oxygen and nutrients take place. The exchange takes place. Here it is again, and I just kind of drew it just because a lot of people think that the blood mixes. It does not mix, the end. So you can see here's the placenta, and so you can see that mom with her endometrial artery pushes O2 and nutrients to this gap, and then the placental vein will pick it up and take it to baby. Conversely, the baby has two arteries, and the two placental arteries will take CO2 and waste to the gap, and mom's endometrial veins will pick them up and take her to her for her to excrete them. Same thing. Oops, sorry. So this is the maternal side. This is the part that's attached to the decidua, and you can see it looks nice. There's not a whole lot of problems with this. It looks nice. It's not white. It's not damaged. It's big. It looks great. Here are the the layers, the amnion and the chorion, which, you know, they kind of shrivel up to the side after delivery, and here's the cord. And here is the fetal side of the placenta. So if the fetus, if it wasn't dark and there was a light inside of the uterus, this is what the fetus would see. But you can see all of this, the baby's blood is in the baby, and the baby's blood is in this placenta, and in this cord, and the baby's blood is in this placenta. And so it just goes to the end of the line, to the condyletons, and then it waits to pick up oxygen and nutrients from the gap, from mom. So if any of these vessels get damaged, that can decrease the amount of oxygen and nutrients that the baby gets. I'm going to show you an example right here. So I'm going to use this white one. So let's say this mom did cocaine, and cocaine causes major vasoconstrictions, or let's say she smoked 5 packs of cigarettes a day. Every time it vasoconstricts and then vasodilates, and the vasoconstricts and vasodilates, it's eventually going to infarct, and then it's going to have a calcium deposit right here. So now this is a block. So now we can't get oxygen past this. These placentas can get all of these calcifications on them with age. After about 42 weeks, this placenta really starts to age. Moms who smoke, they have premature, because this is a temporary structure. So these vessels are very friable and very thin. So you can't have a lot of dilation and constriction and dilation and constriction, or tension or inflammation on these veins, because they will blow. So when they blow, of course, they calcify, and then that prevents oxygen from going to the gap and coming back. So you can see that these would be all places of calcifications. So again, the things that can cause these calcifications are an old placenta after 42 weeks, hypertension, high pressure from the mom on these placental vessels can cause them to infarct. High glucose levels. We know that high glucose levels cause vascular inflammation, and that inflammation can cause infarct in those vessels. Any type of vasoconstricting or vasodilating drugs, smoking, cocaine, any type of constrictor. So we really worry about moms who are exposed to these types of chemicals. Now, are they teratogens? They are not. They don't cause, well, I take that back. High blood sugar can cause heart defects in babies. However, if it's a low-lying high blood sugar, meaning it's in the 200s, while it won't cause a congenital abnormality. So smoking doesn't cause congenital abnormalities. We don't think cocaine causes major congenital abnormalities, but we do know that their CNS network is different, and they do have a higher risk for ADD. Let's see, hypertension and then high glucose. We know that those can cause damage to the placenta, which can make us have a very small baby. But most of those conditions do not cause congenital abnormalities in the baby. Therefore, they're not considered a teratogen, with the exception of cocaine. Cocaine can be considered a teratogen because of the ADD issue, which needs to be studied further. This is just the graphic that I've showed you guys before about, I'm just going to move my thing over here, about in the first trimester, the vascular bed and the endometrium. So you can see here's the myometrium, which is the muscle of the uterus, and then here's the decidua. So the blood volume going to the baby very early is small, but you can see here in the third trimester, this thing is blown open. So if there is a disruption of the placenta, mom is going to bleed much more severely in the third trimester than in the first. And we've already looked at this. This is a teratogen form. And this just shows that the CNS continues to develop all the way from conception all the way through pregnancy. So we don't want any type of teratogen that could alter the CNS, like cocaine. And like Zika virus is a big one. And we even know that children who get exposed to the Zika virus can have brain abnormalities for the rest of their life. So we're very concerned about that. We see heart, limb, lung, upper lip. Most of these really peak before 8 weeks, but then we can see ears, eyes, teeth, palate, and external genitalia. If there is exposure to teratogens later in the pregnancy, they could still have congenital malformations. So fetal circulation in utero, you guys. So babies do not need to breathe air. Move myself. Let's see, I don't even know where I am now. Anyway, they don't need to breathe air, but so what they do is they get oxygen in, and then they have 3 shunts and ducts that bypass the lungs and the liver, because they need the oxygen to all of their growing structures. They really don't need as much oxygen to their lung. The ductus venosus is shunted away. That's the first one, and it's shunted from the inferior vena cava, and it just kind of bypasses the liver. The foramen ovale, the normal adult heart circulatory system is inferior vena cava to the right atrium, to the right ventricle, to the pulmonary arteries, and then it gets all oxygenated. Then it goes up through the pulmonary vein to the left atrium, left ventricle, and out the aorta. We don't need to go to the lungs. So the oxygenated blood comes in, goes to the inferior vena cava, comes up to the right atrium, and goes over through the foramen ovale, a little gate, and it goes from the right atrium to the left atrium, and then to the left ventricle and out to the body. It's great. It does close usually with the first breath that the baby takes, however. And then the ductus arteriosus is the bypass that comes off the pulmonary artery, and it bypasses to the aorta. So that one's open as well. I'm trying to find my recording. Hold on one second. Okay, so I'm gone. But this just shows the fetal circulation. You can see here's the ductus venosus, here's the umbilical cord, and this is inside the baby, so I should draw a picture of a baby. But here's the ductus venosus. Here is the foramen ovale, so it connects the right atrium to the left atrium because we don't need all that pulmonary circulation. And then here's the third one, the ductus arteriosus, that comes off the pulmonary artery to the aorta. So hormones of pregnancy. I'm going to take a quick break and we'll be right back.